Good morning. My name is Johan van Limbergen. I'd like to welcome you to this symposium organized with the support of Nestlé Health Science on the role of food items in the development and the recovery from Crohn's disease. We have put together an excellent panel of speakers, and each of them will introduce their talk now, and then we'll go to pre-recorded sessions. So I'd first like to invite Rotem to tell more about her research and her.
Good morning, and I'm very happy to be here with you today. My name is Rotem Sigall Boneh. I'm a clinical and research dietitian from Israel, and today I will speak about new findings from the Crohn disease exclusion diet.
And then Benoit.
Good morning, everyone. So my name is Benoit Chassaing, and I'm a research director and team leader in Paris, France at INSERM. And we are working on inflammation and the microbiota. And today I'm going to talk about diet microbiota interaction in IBD.
And then Eytan.
Thank you. My name is Eytan. I'm a professor of pediatrics and physiology at the University of Alberta in Canada. I'm a pediatric gastroenterologist with special interest in diet and microbes, and I'll be talking about fiber today. Looking forward to the session. Thank you.
Thank you all. And so as the sessions are pre-recorded, I'd like to invite you to post your questions at the Slido, which we'll then put together at the end for a live Q&A session. So without further ado, Rotem, I'll let you give your talk.
Hi, good morning, and thank you very much for the opportunity to be here today. And I would like to give you some overview regarding the new findings that we have in terms of the use of the Crohn disease exclusion diet in children and especially in adults. Those are my disclosures. So in 2022, we still consider exclusive enteral nutrition to be the first-line therapy for induction of remission in children. But we are becoming more and more aware to see the CDD in other places that are using it all over the world. And this is a nice overview that was published by a group from New York, from Columbia, where they stated the strategies for the management of recently diagnosed Crohn disease. And this nice algorithm, we can see that in moderate disease, patients are having the option to choose either EEN or exclusive enteral nutrition as the official treatment option that they can use. And it is based on the data that we provided over the years. And during the last 2 years, we have more and more studies to support the use of the CDD and the effectiveness of this treatment. And it's especially in adults. And I would like to give you some overview and to discuss those studies today. So what we already know, we have published in 2019 in gastroenterology, our pivotal study in children. We used the Crohn disease exclusion diet, where we showed that it's an effective therapy for induction of remission in children with Crohn disease. And we compared patients to receive either EEN or exclusive enteral nutrition or the Crohn disease exclusion diet together with partial enteral nutrition for 6 weeks. And we showed that in terms of tolerance, the primary endpoint, the patient to receive the Crohn disease exclusion diet were superior in terms of response and remission rate, in terms of the tolerability on EEN. And we can see that there was no significant difference in compliance, and more interested, we can see that the clinical parameters were comparable, and there was no significant difference between those patients who receive either EEN or CDD. And what about maintenance treatment for children? Do we have any data? So basically, we have the Crohn disease exclusion diet phase 3, which include more free diet and more free meals and more options that they can consume along the way. And the idea is to educate them to have some kind of a lifestyle. And we include partial enteral nutrition as much as the patient can tolerate and want to continue. And there was this nice case series that was published just recently from a group from Italy, that they presented their several cases who used the CDD as a maintenance strategy. And we also have the Diatomics Crohn disease study, which is a prospective ongoing open-label randomized controlled trial where we assess the use of the Crohn disease over a period of 24 weeks. And we already included more than 50 patients in the study, and we hope to have the results, and we will see how the maintenance phase works in children as well. And As a children, we always look up to the adult. We want to learn from them, to mimic how they behave. And also in the medicine world, the pediatrician looks up to the adults to see what the new treatment options that are out there and so on. And here we have a unique case where we can see that there is a treatment works well in the children. And the question is if it's working the same in adults. And this is the new study that was published just recently in Lancet Gastroenterology and was led by Dr. Anit Yanai from Rabin Medical Center in Israel. And what we did here, it's an open label randomized controlled pilot study, which we included 44 adults with mild to moderate Crohn disease. And we randomized them to receive either the Crohn disease exclusion diet with partial enteral nutrition used in Modulen for 24 weeks, or to receive the Crohn disease exclusion diet alone without additional formula, but with calcium supplements. We evaluated them with the clinical parameters, and also after 24 weeks, all of the patients did colonoscopy to assess for mucosal eating. What were the results? On the upper panel, you can see the total cohort, and we can see that 70% of patients obtained a response after 6 weeks using the diet, with 62% of patients in total cohort who achieved clinical remission. And at week 24, we can see that 50% of patients were in remission. What about endoscopic remission? We can see that after 24 weeks, patients who did the endoscopic assessment, we can see that 35% of them had endoscopic remission after using the following dietary treatment. When we're looking on the lower panel, we can see here the compare between the Crohn disease exclusion diet with partial enteral nutrition in blue and in red Crohn disease exclusion diet alone. And we can see that even though it seems that there is a trend for partial enteral use of partial enteral nutrition together with the CDD, it didn't reach significance. But again, we can see that there was a trend in favor of using the partial enteral nutrition. And what about the inflammatory markers? So we can see here the every breath index. Again, in total cohort, we can see the significant reductions over the weeks. And also, when we divide the groups, we can see that there was no significant difference in terms of reduction in HBI. And also, we can see that there was significant improvement in parameters such as CRP and a significant improvement in calprotectin level after 12 weeks of using this treatment. What about the mucosal healing? So again, here we can see the simple endoscopic score of individuals, and we can see that most of the patients had significant improvement after following the dietary treatment. Additional study that was published just recently by a group from Poland, and they published their experience with in a prospective study in 32 adult patients with mild to severe disease. They included patients with CDAI from 151 to 562. And all patients did the CDD with partial enteral nutrition for 12 weeks of intervention. And what they showed here, they showed that after 6 weeks, 76% of patients obtained remission. And after 12 weeks, 82% of patients were in remission. In terms of response, we can see that more than 80% of patients respond after 6 and 12 weeks, which is an amazing result. This is just using a dietary treatment. What about the inflammatory markers? We can see here as well, again, a significant improvement after 6 and 12 weeks in CDAI, in calprotectin levels as well. And you can see that there was a significant improvement after 12 weeks, and also in CRP levels as well. What about quality of life? So it's a question that we're asking ourselves a lot. We are changing and modified the patient's diet. It seems that it will cause them to reduce their quality of life. But here we can see that they did provided patients with questionnaire. And when patients are feeling better, their quality of life improved, even if they need to change their diet. So we can see there that here that they published and showed us that the quality of life improved over time after 6 and 12 weeks. Additional strategy that we are trying in our clinic is a short course of EEN following by the CDD. And it might be considered in more severe cases, as we did in our practice, and it might be considered also in hospitalized patients. And also sometimes when patients need the time to get organized and the family need to understand what to do and to be ready with all the food and everything, they can start with the 2 weeks of EEN. We have published in our case series in 2017, 5 patients who did follow this strategy, and 3 of them achieved clinical remission. And of course, we have the diatomic study, which is an ongoing randomized controlled trial, and when we are assessing 2 weeks of EN following by the CDD, and we are looking forward to see the results. And here, a group from Croatia published their experience in a real-world data with a retrospective study in 61 of the patients. And they had, most of them did EEN, but 20 patients followed the CDD with partial nutrition. And you can see here that they used both strategies, either if it was 1 or 2 weeks of EEN before the CDD with partial nutrition or the CDD alone. And in both cases, they achieved 75% of remission, which is amazing results. When we are using dietary treatment, we need to remember that we always need to support the patients, and the support should come from everywhere, from family, from friends, from us, from the healthcare medical, and especially from the dietitian. And we're trying to find out how we can help patients more and more easily. So we have a recipes booklet with many recipes that they can prepare and enjoy for nice dishes. We can provide them with list of specific products that they can buy, example of weekly meal plan, shopping list, meal preparation day advices, and mobile app. And basically, they can all of them. They can find all this information in the mobile app, in the Modulife, and that can help them go through and follow the diet. And though here you can see several of them, many nice dishes that they can be CDD friendly, and then they can use. And another very important issue here is the role of the dietitian, which is very pivotal in the management of patients with Crohn's disease. The dietitian should do the complete nutritional assessment before starting to understand the preferences of the patients and how to adjust their diet, to assess the nutritional status, to make sure that there are no deficiencies, and if they are out there, she needs to address them, and to correct with partial nutrition or with multivitamin. And she needs to have the time and dedication to explain the basis of the treatment, to explain the rationale of the diet and why patients should follow and do those treatments, and also, of course, to increase the encouragement and the motivation of the patients, and to help to solve some difficulties that are out there and to solve some problems. So in conclusion, we saw that the CDD with partial nutrition is an effective treatment for induction of clinical and biochemical remission in children after 6 weeks, as was shown in the RCT, with even better compliance. We also know that the CDD with partial nutrition might be considered as a treatment option for adult patients as well, with mild to moderate disease. Another strategy is a short course of exclusive nutrition followed by the CDD with partial nutrition that might be considered in more severe cases. And the dietitian have a very pivotal role in the management of dietary treatment. And there was a nice review that was published by a group from Poland, and they summarized many of the information that we have on the CDD and how to use it. And they concluded there that it seems that there is a more and more data regarding the CDD. We do hope that it will be in the upcoming next guidelines that all patients will be able to use it and to enjoy from dietary treatment that can help manage them disease. With that, I would like to thank you very much for listening. I will be very happy to answer any of your questions and enjoy the rest of the session. Thank you.
Good morning. I'd like to talk to you this morning on the role of the microbiome in the establishment and also the recovery from inflammation. These are my disclosures. So we know from a range of epidemiological studies that dietary choices and dietary patterns at large matter both in terms of development of disease and disease susceptibility, as well as the course of disease once disease is established. So in this short overview, I hope to show the role of the microbiome beyond simple species analysis or OTU analysis, and move to an understanding of how microbiome modification through, for example, the Crohn's disease exclusion diet can help with the recovery from inflammation, and eventually with a better understanding of how the different products of the microbiome influence disease. So within microbiome science, we've moved from a culture-based approach to a more community-based approach, thanks to the advances in next-generation sequencing. And for the issues at hand in Crohn's disease, I'd like to set the scene with a young boy who was treated here over the last few years in Amsterdam, who presented with a history of bloody stools, weight loss, growth delays, abdominal pain, and a markedly elevated calprotectin and quite severe colonic ulceration. We were opting to start him on anti-TNF-based therapy quite soon after diagnosis, but allowed for a period to get his vaccination status optimized. And during that period, he received a couple of weeks of exclusive enteral nutrition, followed by the Crohn's disease exclusion diet. And because he had such a good symptomatic as well as calprotectin response, we started him only on oral methotrexate and has remained in long-term remission with ongoing dietary modification since. We know from previous work, particularly in the risk cohort, that there are a number of species elevated with active disease, such as the Proteobacteria, Haemophilus, and Escherichia, and Fusobacterium, and another wide range of species really suppressed or decreased associated with inflammation. We know that these shifts in the microbiome happen more often in inflammatory bowel disease and can be more extreme. We know that these big studies with very many approaches in terms of metabolites, microbiome, as well as clinical phenotyping, often leads to a complicated analysis, basically showing time and again that normal processes are disrupted when the activity is at its most elevated. This does bring into question the previous paradigm where we try to extend the period in between bouts of inflammation to try and reduce bowel damage to an even more proactive way of managing disease after the first diagnosis, to really suppress inflammatory activity with a combination of diet management together with, for some patients, medical management, as highlighted in the recent guidelines by the ESPGHAN Porto group and ECHO, where nutrition plays a role in both induction as well as in maintenance of disease. For the Crohn's disease exclusion diet, we've shown in our first analysis using 16S analysis that there is a reduction from week 0 to week 6 in the Proteobacteria. And these cladograms, these circular representations, show that in the center are the higher levels of taxonomy, and on the outer rims, the lower levels of taxonomy, such as the species, and that the Proteobacteria are decreased between week 0 and week 6, and the firmicutes, and particularly the Clostridia, are increased. This was also seen in the exclusive enteral nutrition cohort, where the firmicute expansion was perhaps even more varied. However, from the week 6 to week 12, we see that the sustained changes are there for Proteobacteria only in the Crohn's disease exclusion diet group, because in the group of children who finished their exclusive period of enteral nutrition at week 6 and then resumed a free diet with some supplemental enteral nutrition, the Proteobacteria signal was lost, indicating that there is a rebound back to baseline, whereas the firmicute changes persist. So it's this key change in Proteobacteria that is not sustained. And when we look at dietary non-responders at first and see how they change from week 0 to week 6, we see indeed that there is no big decrease in Proteobacteria. This is rather limited. And when we then compare dietary non-responders to responders, it is indeed the Proteobacteria signal that distinguishes these two groups of children clearly, the Proteobacteria decrease in dietary responders. And Building on that, we've now performed a metagenome analysis where we look at all sequence data from the children participating in the Crohn's disease exclusion diet randomized trial, and then performed metagenome analysis with Metaflan and these novel software packages. We were also able to compare data with a cohort of healthy children for which metagenome data was available, provided by the group of Professor Jim Lewis. And there we showed that at baseline, there was a marked increase of proteobacteria in the group of children affected by Crohn's disease as compared with healthy children. And that at week 6, even though children achieved remission, that these changes were not corrected yet. There was still an abundance of proteobacteria, both for the group of Crohn's disease exclusion diet as for the group of children receiving exclusive enteral nutrition. And by week 12, we see that these microbiome changes are much firmer, but that there is still an abundance of particularly E. coli for the children who are in remission and have remained in remission from week 6 onwards. So the microbiome changes are evolving and are not yet fully back to what we hope they would be, resembling healthy microbiota yet. We see that the children who maintain remission after a course of exclusive enteral nutrition, that these changes are even more pronounced, and that there is a re-expansion of the proteobacteria, as we had previously shown with the 16S data published in the original Gastro paper. When we then try to account for the compositional nature of the data, correcting for Bacteroides as a more stable group of organisms in the microbiome, we showed that diet-induced remission is indeed associated with a significant reduction of proteobacteria rather than the firmicutes, which remain more or less the same across time points. And we've recently published in the Journal of Crohn's and Colitis these changes when we look at co-occurring groups of organisms. So the organisms changing over time really occur as a group of organisms, and the changes that are mostly impacting the proteobacteria impact on the wider community, and this can be visualized in novel ways, showing the interconnectedness of these organisms. We've also looked at key metabolites, such as short-chain fatty acids, and there we've shown that the Crohn's disease exclusion diet does not lead to reduction in either acetate, propionate, or butyrate, whereas exclusive enteral nutrition does. And this is most evident at week 6, after a period of exclusive enteral nutrition within this group, virtually no fiber being provided, after which there is a recovery when FRIO diet is resumed. So clearly, short-chain fatty acids are not the key mechanism as both groups enter into clinical remission. We've also looked at changes in bile acids. And there we've shown that for the group of exclusive enteral nutrition, there is a quick change in the amount of total primary bile acids, but over time, the secondary bile acids really are not changing with either diet, reflecting really the capacity of the microbiome over time to metabolize primary bile acids to secondary bile acids. We had previously shown, using more cross-sectional data, that the composition of the microbiome reflects the capacity to deal with primary bile acids, and that in children with an unfavorable long-term course, there is a predominance of primary bile acids, but the setup clearly of the Crohn's disease exclusion diet cohort was different. In more recent analysis, we've shown that diet-induced remission is associated with shifts in the metabotype towards healthy controls. And on these axes, we show that the overall capacity of a healthy microbiome, as shown here in the M1 metabotype, it differs from the more disease-associated microbiome capacity metabotype, M2, particularly for some subsets dealing with phosphorylation. And we show that over time, you can really change also the metabolic capacity of the microbiome and the key species associated with that from a disease-associated microbiome to a more healthy microbiome and a healthy metabotype. And these changes increase as you continue your weeks of the Crohn's disease exclusion diet. And more recent analysis, we've also looked at individual metabolites, and there we've shown that particularly kynurenine is affected by the nutritional therapy, both combining Crohn's disease exclusion diet and exclusive enteral nutrition in this group, with a clear difference in these principal component analysis between a week 0 metabolic profile and a week 6 metabolic profile when remission is achieved. When we look at the metabolome of only the children in the group of the Crohn's disease exclusion diet with partial enteral nutrition, we see a number of changes. Again, the kynurenine is reflected, but also changes in the pyruvate cycle and some amino acids, which will be expanded upon in the submitted paper. We also show that there are key differences that are worth following up and hopefully become biomarkers of a successful dietary therapy in the future, but more is there to follow. So in conclusion, I hope to have shown that dietary patterns matter in terms of risk of development of disease and disease course, and that we can take lessons from the knowledge of how the microbiome develops, particularly key taxa in that development, to see how we can modify the microbiome favorably with nutritional therapy. See that the Crohn's disease exclusion diet is able to sustain these microbiome changes, whereas exclusive enteral nutrition is not, and is associated with the rebound of some of these microbiome species associated with active disease. In the future, these multi-omic approaches will hopefully be integrated with clinic. With that, I'd like to thank you and happy to take questions.
Okay, good morning, everyone. So today I wanted to talk about how some food additives can play a role in inflammation, especially in Crohn's disease. And in order for me to do so, I of course want to talk about the intestinal microbiota. So very briefly, we know that this intestinal microbiota is playing a dual role in the intestine, where it can play some beneficial role, but it can also play some detrimental role, and especially driving, nourishing and promoting chronic intestinal inflammation, as well as metabolic deregulation. And there is definitely a lot of data accumulating, demonstrating that this microbiota can play a central role in driving Crohn's disease in some patients. And there is also more and more data demonstrating that food additives can actually be one dietary player that can drive this microbiota from a beneficial state to a more detrimental state. And this is exactly what we are studying in the laboratory, and trying to understand how some food additives can drive the detrimental impact of the microbiota on the host, and ultimately leading to chronic intestinal inflammation. So regarding food additives, there is a lot of data, for example, regarding artificial sweetener, regarding food colorant. For example, there is this recent study demonstrating that some food colorant can be metabolized by the microbiota, ultimately driving chronic intestinal inflammation. But what we and others have been studying in the past 10 years is more dietary emulsifiers, which are again food additives that are highly used by the food industry. And I'm going to present you some data demonstrating that they can indeed play a role in both preclinical and clinical settings in driving the microbiota from this beneficial state to this more detrimental state. And what's very interesting, if we take a look to this summary presented by Jean-Frédéric Colombel and Jim Lewis regarding the allowed component of various diets that are used in Crohn's disease patients, you can see that dietary emulsifiers are not allowed in many dietary interventions used in CD patients. And this is especially the case for CDED. So of course, there is other dietary components that are not allowed to be used. But again, this highlights that maybe dietary emulsifiers can play a role in the beneficial aspect of those diets used in Crohn's disease. So very briefly regarding dietary emulsifiers, are highly used by the food industry in order to extend shelf life. And what we did in the past was mostly focusing on carboxymethyl cellulose or CMC, and polysorbate 80 or PAT. And first, when looking at microbiota localization, you can see that the microbiota is normally kept at distance from the mucosa. You can see those bacteria here labeled in red
are kept at a safe distance from the surface of the mucosa with a distance of approximately 25 micrometer. When we treat the same mice with either CMC or PAT, you can see that we have a decrease by approximately twofold of this distance, with microbiota really encroaching upon the host and getting in close contact much closer to the mucosa. And we also measured microbiota, what we call microbiota pro-inflammatory potential. So you can see in water-treated mice, this microbiota pro-inflammatory potential is staying pretty stable over time. And this is measured by using fecal flagellin and fecal lipopolysaccharide, which are good markers of chronic intestinal inflammation, of pro-inflammatory potential of the microbiota. While when we treated the mice with either CMC or PAT, you can see that not only the microbiota is getting closer to the mucosa, but it also expresses much more molecules that are highly potent in their capacity to induce intestinal inflammation. So of course, the phenotypical consequences were an increased incidence of colitis in those mice, where you can see in mice treated with water, we have an colitis incidence of approximately 40%, while in mice treated with CMC and PAT, we have at least twice the incidence. And also the colitis observed in those animals were much more severe compared to the colitis observed in the control group. So clearly demonstrating that both CMC and PAT can drive chronic intestinal inflammation in genetically susceptible hosts. And in terms of mechanism, very briefly, what we did then was to try to understand if it was more the mucus layer that was the direct target of the microbiota. And in order for us to do so, we divided the system and we used germ-free mice. And in those mice without any microbiota, we observed that they were completely protected from colitis and from chronic intestinal inflammation. While on the other hand, when we used in vitro microbiota that were treated with emulsifiers, we were able to reproduce what we observed before in the conventional mice. And when we transplanted those in vitro treated microbiota to germ-free mice, it was sufficient to drive chronic intestinal inflammation. So what those data were demonstrating is that microbiota is really the direct target of dietary emulsifiers, but the microbiota, there is some way, and we are currently working on it, there is some way that the microbiota can detect and sense dietary emulsifiers, and in response, they are going to be much more aggressive and drive chronic intestinal inflammation. And there is also this very interesting concept that I think is very important for the dietary management of Crohn's disease patients, is this concept of inter-individual variation and personalized nutrition. And this is especially the case for dietary emulsifiers, because we observe that some microbiota are actually completely resistant from dietary emulsifiers. So even if we treat the mice, they are never going to respond in a detrimental way to dietary emulsifiers. However, there is, on the other hand, there is some susceptible microbiota that host some select species in their ecosystem that when treated with dietary emulsifiers are going to respond, are going to acquire a much more pro-inflammatory potential, are going to encroach upon their host in order to drive and lead to chronic colitis and chronic intestinal inflammation. So I think this is a concept that's very interesting, and this is definitely something that we're also highly studying in the lab. So of course, everything I presented so far was done in mice, in preclinical study. So we also wanted to have some human relevance for those findings on dietary emulsifiers, and this is what we did with Gary Wu and Jim Lewis from University of Pennsylvania and Andrew Gevers from Georgia State University in a study that we called FRESH for the functional research on emulsifiers in human. And here what we did was to have, so this was a pilot trial, so we had a limited number of participants that were divided into two arms, either subjected to an additive-free diet, or the other arm were subjected to the same additive-free diet for 4 days in order to have a washout of the emulsifiers that were consumed before the study. And then they were treated with CMC only, so the study was focusing on carboxymethyl cellulose only for a period of 11 days. And what we observed, even with such limited number of participants over such short period of time, we analyzed fecal microbiota composition, we analyzed the metabolome, and we also were able to collect some biopsies from those participants. And what you can clearly see here is that just even on such limited number of participants and over such period of time, such short period of time, consuming CMC is sufficient to alter microbiota composition. And this is what's represented here. You can clearly see the different clustering between the two groups. And it was also sufficient to drive a decrease in microbiota alpha diversity, which we know is something you want to avoid while the alpha diversity was pretty stable in the control group. So yeah, even in humans, there is definitely something that's happening in terms of alteration in microbiota composition and function when consuming CMC. And in terms of metabolome, so this is a metabolome over time only for the control group. You can clearly see that this is pretty stable over time. There is some day-to-day variation, and this is entirely normal when they were on the additive-free diet. But when we plot the same data for the CMC group this time, you can see that during the CMC exposure time, and this is what presented here with this rectangle, you can see that we observed a very drastic and pretty rapid depletion in many fecal metabolites. So we don't know yet really what's the mechanism of such depletion, but yeah, clearly there is definitively here again demonstrating that the CMC can directly target the microbiota in human as well, driving depletion in many metabolites. And in terms of analyzing biopsies, this is what we did also, and it was pretty surprising to us to observe that in most of the patients, actually consuming CMC was not driving any alteration in terms of microbiota localization and microbiota encroachment, while in 2 patients, it was driving a very strong and very rapid microbiota encroachment. So in those 2 patients, microbiota was getting much closer to the mucosa. So this was bringing us back to the concept of CMC resistant participant and CMC sensitive participant that was maybe driven by the microbiota. So this is what we wanted to try. So we went back to mice and using germ-free mice that are susceptible to colitis, we transplanted them with the microbiota from either 2 insensitive participants or 2 sensitive participants. And after fecal microbiota transplantation, we treated them with either water or CMC. And what you can observe here, especially for the histological scoring, you can see that when we treat the mice that were receiving microbiota from CMC resistant, you can see that even when we treat them with CMC, there is actually no intestinal inflammation that's happening. So there is no colitis in those animals. When we did exactly the same, but this time for mice that received microbiota that we think are highly susceptible to CMC exposure, you can see that we indeed were able to reproduce what we observed before in mice model, demonstrating that yeah, CMC is definitively able to drive chronic colitis in mice, but only if the mice is hosting a select microbiota, and it seems very interesting to keep studying those aspects in order to understand what's driving the susceptibility to CMC exposure in those 2 microbiota compared to those 2 microbiota, because here again, all the participants were healthy individuals. So we don't really know yet what's the difference and what's driving the susceptibility to CMC exposure. And exactly the same was observed in terms of microbiota encroachment, where you can see that only the mice that received microbiota from CMC susceptible participants are presenting a strong microbiota encroachment, while the participants that received CMC resistant microbiota from CMC resistant participants are fully protected against such phenotype. And another important aspect that we are highly studying in the laboratory is regarding other food additives, because there is many other classes that are proved to be used, and they are very often used together. So you see this is a table of co-occurrence, and you can see that there is some food additives that are almost always put together in food products. So for this, we set up an in vitro microbiota system that allows us to cultivate an in vitro in a stabilized manner human microbiota. And what we can observe here is, so first, of course, we are able to reproduce what we observed before regarding the detrimental impact of CMC and PAT. But when screening a lot of different additives, we are able to observe that some of them are indeed really bad in terms of their impact on the microbiota. This is especially the case for the carrageenan, while some others, such as the lecithin, for example, seems to be to have no effect, no detrimental effect at all on the human microbiota. So I think this is again a very important point, because not all the emulsifiers seems to act the same on the microbiota, and maybe we should favor the use of the less detrimental one and avoid using the more detrimental one. So with that, this is everything I wanted to say, and I would be really happy to take any questions. Thank you.
Good morning, everyone. I'm going to speak to you about fibers and their role in inflammation and recovery in the context of the Crohn's disease exclusion diet. These are my disclosures, and I'd like to point out mostly the funding from the Weston Foundation for some of the work I'm going to be showing. So after hearing about the updates on the Crohn's disease exclusion diet overall and the role of the microbes and emulsifiers, fiber is certainly something that has grabbed our attention. And I'm going to set the stage by discussing the typical beneficial roles of fiber that are supported by quite a bit of data in IBD, but also recognizing that not all fibers are the same. We do have some preliminary data that I'll share with you unpublished, suggesting that fibers may be more complex than many of us have appreciated before. And I'll try to put this in context and come up with an approach for what we should be discussing with our patients. So what are fibers? Fibers are complex carbohydrates. They are typically found in cell walls. They are non-digestible, so our enzymes are not able to break these down. And as you can see over here on the right, they are kind of built as monosaccharides that are attached by complex compounds. They are typically found in plants, mostly fruits, vegetables, and grains, but can also be found in fungi and certain animals such as insects, which I'll discuss a bit later. We talk about three major features of fiber. There's solubility, their viscosity, and their fermentability. And the fermentation is really key to the role in the gut health as these are fermented by resident microbes. Many of us are very much aware of the beneficial roles of fibers and their products, and this is illustrated here. So typically what happens, fibers which are not digested by human cells are then fermented by gut microbes, and byproducts such as short-chain fatty acids and specifically butyrates are produced. And these will really lead to the beneficial roles that I mentioned. And these can be from anywhere effects on the barrier, innate immunity, adaptive immunity. And for many years, we've known about the good roles of fiber in this setting, and certainly we'll keep on pointing to that direction. This is supported by human data. So on the left, you can see a very large cohort study, and on the right, a case control study, both showing that diet is associated, so previous diet is associated with developing IBD, and that fiber or foods containing fiber may have an important role. And this is really a lot of the basis for the Crohn's disease exclusion diet. And we've dealt for many years with the question whether it is the lack of fiber, for example, or the presence of the Western diet and food additives, as we heard just in the last talk. We've summarized some of these in this review over here on the left. A lot of the focus was on the foods that may be through different mechanisms causing damage that would lead to the development of IBD, or at least will show a challenge that we have with resolution of inflammation. But certainly the plants and fibers were identified quite early on. And that's why the Crohn's disease exclusion diet, in addition to removing all of the foods that are mentioned over here, did put an emphasis on the addition of fruits and vegetables. And that's probably part of the mechanism by which this works. In this later review, we went into more details to understand what the mechanisms are. And on the left, you can see the effect of different dietary factors on microbes and their function. And on the right, on the host side, mainly on the mucosa and the epithelial layer. And you can see that dietary fibers or lack of fibers has certainly been linked in cell and animal studies to many of these features. One study I'd like to highlight was published a few years ago in Cell, and it really illustrates the importance of fiber in gut health. So in these mice who were germ-free, but that were then introduced with human bacteria, as long as they were receiving a fiber-rich diet, their mucus layer was intact. But once they were deprived of fiber, we can see that the microbes changed. They actually consumed the mucus layer. And as a result, there was damage to the epithelial layer as well. So fibers obviously are very important. And I think that's something we've all known. That's reflected in different guidance for our patients, such as the IOIBD guidelines shown over here, where fruits and vegetables are thought to be protective and should be encouraged in patients who are at risk for IBD or patients who have IBD. Many of the food guides that we have, for example, in Canada, where I live, will put an emphasis on plenty of fruits and vegetables and grains as a good source of fiber. And obviously there are benefits beyond the gut in that setting. However, for many years, people have been following advice that is really quite unsupported, that they need to avoid fiber and be in a low residue diet, especially in the setting of ulcerative colitis. And when we speak to our patients, many of them have somehow been exposed to this and are following this advice. Furthermore, there is some research and some studies have shown that IBD patients describe an increase in symptoms with fiber, and as a result, many of our patients are avoiding fiber altogether, despite the very good evidence we have for the beneficial role of fiber in the setting. This has really stimulated my interest in fiber, and we published this review last year where we looked at the different variety of fibers, and as you can see over here on the right, the origin of the different fibers varies from the different types of food that we eat, so not all fibers are the same, as do the microbes that are impacted by these fibers. As a result of that, the byproducts that are produced could be affected, and the biological impact could be affected as well. So putting this in a different way over here, we can see that in the healthy gut, we have different sources of food, and the size of the font represents the relative contribution of the different fibers. This will then impact the microbes, the production of the byproducts such as short-chain fatty acids, and typically will lead to a happy gut. But what happens in IBD? This project has been really spearheaded by Heather Armstrong, who was a postdoc in my lab for the last 5 years and now has her own lab at the University of Manitoba, where we asked this question specifically. And what we felt was that in the IBD setting, diet is different, microbes are certainly different, so everything that we see may impact the gut and have a contribution to the development of disease. When we were reading about this a bit more, we came across this study, and there are several other studies that showed similar findings where fiber may not always be a good thing. And we have to remember what I mentioned earlier on, that the same molecular structures are also found in fungi, for example, or other potential pathogens. And as a result, our immune system has developed ways to respond to these specific components. So over here, what we see is beta-glucan can actually bind, in this case, Dietin-1, which is a receptor found on immune cells, and that can result in a pro-inflammatory response. This led to the development of the following hypothesis that dysbiosis in IBD patients with a specific known lack of fiber fermenting microbes could result in unfermented microbes going through the gut and being exposed to the immune cells. This intact fiber may then bind host cell receptors and stimulate a pro-inflammatory response. In order to test this hypothesis, we undertook an extensive study, which we're now hoping to publish, and it's under second review in Nature, where we took biopsies from over 100 patients, children, either without IBD or with Crohn's disease or ulcerative colitis at different stages. We incubated them in the setting ex vivo and exposed them to fiber and looked at the results. And the main outcome over here is the production of interleukin-1 beta, which is a pro-inflammatory cytokine. As you can see in non-IBD individuals and those in remission, there was no increase in the IL-1 beta when these biopsies were exposed to fiber. But with active Crohn's disease or ulcerative colitis, we did see a significant increase in IL-1 beta. We looked at different cell lines that might mediate this, and what you're seeing over here is macrophages, which were stimulated by these fibers, specifically inulin and fructose oligosaccharide, or FOS, but not by other fibers shown over here. We then asked whether the microbial environment might be contributing to this, and we tested this by taking luminal washes, so intestinal washes representing the microbes at the mucosal layer, and incubated these with cells. We pre-fermented these fibers with the bacteria or without the bacteria. And what we found was that in non-IBD patients or those in remission or mild disease, pre-fermentation with the microbes of FOS did lead to a reduction in IL-1 beta, whereas in patients with active disease, the microbial community was not able to ferment the fiber, and short-chain fatty acid analysis showed that that was indeed the case. And as a result, we had an increase in the IL-1 beta. We then correlated this microbe response with the mucosal response shown over here on the right, suggesting that that indeed is the mechanism for this effect. Finally, in the study or the preliminary data that I'm showing you, we also went back to our patients and tried to see how their diet correlated with this. And over here, what you're seeing, using food frequency questionnaires, we were able to extract the amount of fiber that our patients were exposed to in the diet. And we found a negative correlation for both Crohn's disease and ulcerative colitis between the consumption of oligofructose and the ability of the biopsies of those patients to respond to the fiber ex vivo, suggesting that patients who are avoiding fiber seem to have an increased inflammatory response. And this subpopulation may indeed suggest that this is part of the mechanism for developing this condition over time. So putting this all together, I think it is important to try and put this into proportion. These are very preliminary findings, and I think we have to be cautious about what we mention to our patients. And certainly the Crohn's disease exclusion diet is a great example for this. So fibers are important for gut health, and most of us should be consuming fiber. As we've seen in the Crohn's disease exclusion diet, indeed, this is likely a beneficial compound, but the complexity is a lot more than I appreciated before. The response to fiber does depend on many different factors, including the diet, so which fibers we're consuming, the microbes that are there, the gut barrier, and I haven't shown you some data on that, the specific immune environment, and whether or not you have active inflammation. What we've shown is that during active disease, some fibers may possibly have a pro-inflammatory response, and that's something that we need to further investigate, and we are embarking on a trial to try and define that in a bit more detail. What's really important for me is that our patients should not be avoiding fiber because of this research or because of anything else. And again, the Crohn's disease exclusion diet represents that quite well because they are not all the same. And this highlights, again, the need for personalized dietary approaches, which I believe are really the way of the future. With that, I'll end. I just want to mention again, Heather Armstrong, who was instrumental to the study and is now with a grant that we both got from Weston Foundation. We're working on this together to further highlight, and others who've contributed to this work. I thank you for your attention and looking forward to any questions.
Thank you very much to all speakers, and we'll start with some questions that we've been given through the Slido. So maybe first to Rotem, in your experience, and I know you've just published on this, what would predict response to diet from a clinical and clinical care point?
Okay, thank you for the question. There are several things that we need to take into consideration because, first of all, it's very difficult to try to predict from the beginning. There are several studies to show and to try to predict with EEN. And what we try to do with the CDD, we showed that after 3 weeks of using the CDD, where it's short course, we can understand already if the patient is responding to the diet or not. So to find out from the beginning some parameters that will let us to predict the response, it was difficult and challenged. But after 3 weeks, we saw that most of the patients had already responded after 3 weeks in terms of the CRP levels, the inflammatory markers, and also in terms of the clinical response. So we should try and give patients for a short course and then to see if we should continue or not.
Yeah, and maybe a question to Eytan. What do you think the role is of the CDD in the management of Crohn's disease preoperatively? Would you use it, or would you just stick with exclusive enteral nutrition?
That's a great question. I have to say that the ideal patient for CDD would probably not be a patient going into surgery, but in selective cases, I would use that. So the benefits of EEN are the healing effect that is always relevant, but certainly the fact that it's a liquid diet is very relevant for that setting. Patients who can't tolerate EEN, I think CDD might be considered, but if they have obstructive symptoms, then I would probably try to avoid full foods.
Yeah. Then we have a question to Benoit. When you look at all the different fibers and all the different emulsifiers, how do you hypothesize the differences are explained between the effects of these different emulsifiers on the mucus layer?
Yeah, that's a good question. We don't really know actually, so we are working on it. I think it's matter the structure of the emulsifiers is very likely mattering, and as well as how they are incorporated into the food matrix. So we think that some of them will be made more available to the microbiome, and so they can exert their effect on the microbiome. We are currently trying to identify what molecular signaling pathway in the bacteria are detecting the emulsifiers. So once we identify those, we'll be able to screen a little bit better and understand a little bit more this point. But I think that's definitely a very good question. And the clear answer, the short answer is we don't really know yet.
Yeah. And in different parts of the world, there are different agents that are used to treat fresh food, and that perhaps explains some of the differences we see in response to diet. Do you have any experience on how those agents used in crop spraying affect the microbiome or the integrity of the mucus layer?
Yeah, so this is not something we are studying directly in the lab, but we are collaborating on some of those aspects just to see the direct effect on some pesticides and crop agents on the microbiome, and yeah, there is definitely interaction. So yeah, we don't know yet the relevance to the IBD community and if it can alter the microbiota in a way that would predispose to inflammatory diseases. But yeah, there is definitely interaction with everything that we ingest with the microbiota composition and function.
Yeah. Okay. Eytan, maybe another question for you. How do you reconcile the findings with EEN that there's a drop in short-chain fatty acids, particularly butyrate, and then the findings of immune regulation with fibers?
So what I've learned over the last couple of years is that the very simple way as a physician of trying to understand diet doesn't work. It's much more complex than we think it is, including the byproducts such as short-chain fatty acids. Probably the best answer to any question in science is it depends. And I think that the local circumstances in the gut are quite variable. Specifically regarding why EEN will lead to lower butyrate, I think that that's just a question of substrate. So without having the fiber that we have in food and other sources that will feed the right microbes, we expect to see a reduction in short-chain fatty acids. Generally speaking, most of the effects of short-chain fatty acids are beneficial. But I think that if we're looking at diet as a complex intervention, as we have in EN or in CDD, then it's not going to be summarized into one simple component. There are going to be many other facets to it. So it really depends on the complete effect. There have been attempts to treat with butyrate enemas, for example, and I think that the effects have been quite limited. So I don't think that that alone is a major factor, but it certainly is an important factor in the biology of the gut. So I don't think I gave a very simple answer because I don't think there is one.
Okay, thank you. Rotem, back to you. When you're counseling patients to go through the first and second phases of the CDD, what do you do about monitoring calprotectin? Do you monitor it after each phase? And what do you do if there's an unexpected rise or not a decline as much as you'd hoped?
First of all, we learned over time that the calprotectin levels needs more time in order to see the effect of it. So usually we're trying to monitor it after 12 weeks, after completing both phases, because we think we need a little bit more time. If patients are already dead after 6 weeks, we need to see the overall picture here, because if they had a response and the inflammatory markers had a reduction and only the calprotectin levels had raised, I would try to wait a little bit for 2 weeks and then continue and follow to the second phase and continue monitoring it. Because sometimes the calprotectin levels, the effect on it, it's challenging and it's not the same as we are predicting. But after 12 weeks, usually we can see already the reduction and the improvement. So I think we should just give it a little bit more time to understand the physiology. And again, we need to take into consideration of all the picture and how the patient feels, and together with the inflammatory markers as well.
And are there situations that you actually say to prolong phase 1?
Yes, there are cases because sometimes patients need a little bit more time. They had a response, and then the CRP levels are still a bit high. And then I will ask them to continue for 2 additional weeks, assess again, and to see if they can then move on to the second phase. Sometimes actually we'll tell them to continue to the second phase, but we'll ask them to wait with the gluten exposure and the meat exposure just to see if it might help them to stay in this, and they need a little bit more time in order to have the same effect. Okay,
maybe one final question. What do you do, Rotem, with patients who have allergies or are keen to stick with a vegan or vegetarian diet?
Okay, this is a great question that is coming up a lot in terms of the mandatory foods. As we mentioned earlier, the main mechanism of the diet is the exclusion of the dietary components that are potentially pro-inflammatory. But in saying that, patients are not mandatory to eat all the mandatory foods. The mandatory foods there, it's only in terms of improving the nutritional point of view. So I would consider just to have a sufficient amount of protein. So patients who are vegetarian can follow the diet without eating the chicken breast as long as they have a protein source, whether if it will be eggs or more formula that will provide them, and as a dietitian I will make sure that they will receive enough. In vegan, it's a little bit more challenging, and sometimes we are doing a negotiation with the patients to understand where are the limits and exactly how many fibers they should consume. But again, they are not mandatory to eat all the foods there. It's something that the dietitian should follow and just make sure that the patients have sufficient amount of protein.
Okay, thank you very much. And with that, I'd like to bring the session to a close. Thank you very much to Nestlé and to all speakers for their excellent talks. And I wish all of you attending a good continuation of the ECHO conference.